important topic about IGF-1 deficiency, which is a disorder which we encounter very commonly in clinical practice, and it has implications in terms of assessment and management. So, what are the various causes? वहाँ से brightness देखो. So, what are the various causes of IGF-1 deficiency that you encounter in clinical practice usually?
Most commonly, growth hormone deficiencies that causes IGF deficiency, like any isolated growth hormone deficiency or multiple pituitary hormone deficiency.
So most likely either the growth hormone is not there or it is not working. So how do you differentiate between growth hormone deficiency and insensitivity clinically? Are there any clinical clues? Yeah.
Sir, in growth hormone insensitivity, there will be frontal bossing, sparse hairs. There will be more severe growth failure.
So normally the height will be much more affected. Second, can you have antenatal growth failure in a pure growth hormone deficiency?
No, not possible, sir.
Very unlikely. But you can't say not possible, but maybe it's less likely. While you can have it in specific conditions of growth hormone resistance. Third, you said that they will have more of coarse facies, sparse hair, and other parameters which will be there. So, Dr. Nimisha, what are the pointers about IGF-1 deficiency in the newborn period?
So, prenatally, there will be growth. In fetus life, there will be less.
No. So, when I say IGF-1 deficiency, it does not mean that there is a growth hormone resistance. Anything is IGF-1 deficiency. You can classify IGF deficiency as a primary problem or a secondary problem, or growth hormone deficiency or resistance. So what I'm trying to say that anybody whose IGF-1 is low, what are the pointers you will see in the newborn period?
So both prenatal as well as postnatal growth will be retarded. There will be blindness.
More importantly, what may be the only sign which will tell you that this is a IGF-1 deficiency? Micropenis, hypoglycemia. Those things, of course, will be a much better pointer, and growth may or may not be affected, because that's something. If it's a pure GHD, if there's a growth hormone resistance because of Laron syndrome, the growth will be normal. Thinking about any condition in which IGF-1 levels are low, it doesn't really imply that we are dealing with only growth hormone resistance or growth hormone non-responsiveness. So we'll talk a bit about physiology. So we are all aware that the growth hormone IGF-1 axis involves the secretion of the growth hormone releasing hormone, which acts on the pituitary on the growth hormone releasing hormone receptor to produce growth hormone. And along with that, you have got an inhibitory mechanism of somatostatin. Now, what is the major tone as far as the hypothalamic tone for growth hormone?
It will be mainly the somatostatin-induced negative tone will be.
So normally the growth hormone is inhibited by the hypothalamus.
No, that will the somatostatin tone will be causing the growth hormone pulsations.
No. So, and what I'm asking is, it's a very specific question. What is the tone for growth hormone?
It should be stimulatory.
It's stimulatory, because otherwise you will, when you cut the hypothalamus or the infundibulum, if it is stimulatory, you will have deficiency. If it is inhibitory, you will have excess like prolactin. So generally, your GHRH is continuously stimulating growth hormone. Now, what is somatostatin doing there?
Somatostatin is actually inhibiting the growth hormone pulses.
Yes, so it's like a second mechanism. When you don't want the growth hormone to be there, somatostatin will be there. So now when you are saying the point of pulses, what does it mean? When your somatostatin goes down, your pulses come up. So it's like a regulatory mode. But predominantly the body is ready to produce growth hormone because GHRH is there. It is kept in check via somatostatin. Now, somatostatin is a very interesting hormone. It is an inhibitor of secretion of many hormones. So, which all hormones, Dr. Sandeep, does somatostatin inhibit? One, of course, we talked about growth hormone. What else?
Glucagon, sir.
Yes, what else? So, when it suppresses glucagon, it will also suppress?
Steroids, sir.
Insulin? So if you think of it, where all do you use a somatostatin receptor agonist? Most commonly you're using in growth hormone excess, number one. You use it? Hyperinsulinism. That is the second major thing. So insulin will be the second one. Then prolactin, it is like not a main treatment, but yes, very refractory cases. Before that, TSH secreting adenoma. So somatostatin is an inhibitory one, not only for growth hormone, but also for ACTH, for TSH, for prolactin. And when you go to the pancreas, both alpha and beta cell. It's produced by which cells in pancreas?
Delta.
So it's a different mechanism. So it's controlling both glucagon as well as the insulin. But if you talk about the hypothalamus, it's pretty much inhibiting most of the anterior pituitary hormones. And when you're using somatostatin receptor, so what does it mean? If you use it for hyperinsulinism, what will happen to growth?
Growth will be affected, sir.
Growth will become less because you're effectively causing growth hormone deficiency from that perspective. Now, growth hormone basically binds to the growth hormone binding protein and when it is traveling in the circulation. Now, do peptide hormones have binding proteins? Which hormones have binding protein largely? Vibha? Generally the steroid hormones. So what are the two major peptide hormones that have binding protein? One is growth hormone, which we've discussed here. Yes, IGF-1 and growth hormone. Why? A lot of PTH also travels, insulin also travels. So what is exactly? Yes, so what exactly is growth hormone binding protein?
It's secreted by the liver along the
What exactly it is? Yes, so what you need to understand, it is secreted by growth hormone responsive tissues. It's actually the part of the growth hormone receptor. So you can think of it in a very interesting way that suppose this particular organ wants the growth hormone to act. It is sending like you put for the fishing, you put a bait, and growth hormone binding protein is like a bait. It's the extracellular domain of the receptor and it pulls it down there. So growth hormone binding protein, as you said, is one way of targeted action. So when we talk about the action of hormones, we say hormones are everywhere. Growth hormone is everywhere. Why is it that only the cartilage, only the liver responds to growth hormone and not, let's say, retina? Maybe it is responding, but the responsiveness is differential in different organs. What is the basis of organ selectivity of hormone action?
There are some specific receptors on the.
So one is receptor, second
second is some special enzymes are sometimes there which can
metabolize, activate or inactivate. Good. What else?
Binding proteins that
Like
carry
these
the
binding proteins. So binding protein are not just for binding. So for steroids, we know it is basically to carry them because they are lipids. They were not going to flow in the blood. So you need to have specific binding protein to take them. But here the role is to more to like take it to its site of action, and very importantly, which Dr. Vibha talked about, is to increase the half-life. Now, what is the implication therein? So if your binding protein is less, your half-life will be less. So you will be metabolized quickly and your action will effectively be less on that regards. So now growth hormone is taken by, it's chaperoned. It's like you've got somebody who's taking growth hormone to its site of action. The classical view is that the major site of action of growth hormone is the liver, where it acts via the growth hormone receptor to produce IGF-1. And we all know about that. This is the growth hormone releasing hormone, growth hormone, IGF-1 axis. And there was a somatomidin hypothesis, which was very, very popular, which was basically there, which suggested that all the actions of growth hormone are mediated via the IGF-1. Now, IGF-1 is a very interesting molecule. It was basically derived as a identified as a hypoglycemic hormone and then as a sulfation factor. So people, when they were studying in terms of the growth hormone action, what they realized was that if you have a hypophysectomized rat and you expose their extract in the chondrocyte, the growth is not there. But if you really give growth hormone, the response will not happen unless you have a mediator. So finally, what they realized is that the growth hormone action is mediated through this compound, which was later found to be structurally similar to insulin-like growth factor 1. Insulin, that's why it's known as insulin-like growth factor. And there are many insulin-like growth factors. How many IGFs are there?
10, sir. The IGF-1 and 2.
2. IGFs are 2 and there are many binding proteins. And IGF-1 and IGF-2 are quite different. We'll talk about that. One of them is an endocrine or a paracrine one. The other one is the local effect. Now, IGF binding protein is also produced by the growth hormone. So what are the three major products of the growth hormone after action on liver? I've told about 2. What is the third one? So IGF-1, IGF binding protein and there are three peptides which are bound, and then that complex, the ternary complex, the three things is the
Acid labile.
ALS. So that's the acid labile substrate.
substance.
So what this tells you is that IGF-1 and IGF-BP are basically, BP3 to be more precise, are markers of growth hormone action. Now, what is the role of IGF-BP3?
So it will bind to IGF and one and targeted action to the chondrocyte.
It is not going to allow it to be leaked. So if suppose you want a paracrine action, it will keep it bound to the particular tissue and it will increase its half-life also. So in conditions where you have more IGF-BP, what will happen, and where there is no IGF-BP, what will happen?
More IGF-BP, more action of IGF-1.
So longer duration of action, and at one time your levels will not go up. It's like if you do not have a bank account, you get a lot of money. It is going to be very high for a few days and then you are zero. So this is what will happen if you only have IGF-1. While if you also have a bank account, you will deposit, from which slowly release will happen. It's like a rapid acting insulin versus a long acting insulin. So what does it really mean in that perspective? It means is that if you give growth hormone, you will produce both IGF-1 and IGF-BP. While if you give external IGF-1, you won't have IGF-BP. So now you tell me which one is better. You want to give growth hormone to produce both IGF-1 and IGF-BP, or you just want to give IGF-1 from outside?
Growth hormone.
Because your acute rise in IGF-1 will not be there. So all these concepts of free IGF-1 levels being going up, which are detrimental, will not be there. And your effect will be sustained. So the message is that the IGF-1 therapy is inferior to growth hormone therapy. I'll talk about some other reasons as well. Predominantly because you won't have an increased IGF-BP. You need to give a more frequent dosing. You will have a higher risk of complications of high IGF-1, and you will of course have hypoglycemia. So that becomes important from that regards. So we have talked about this pathway as to how growth hormone activates the IGF-1 and IGF-BP, and these are then going to act on the growth IGF-1 receptor to cause chondrocyte growth. So this is the conventional hypothesis which is there. I'll talk about what is the newer aspects in that regards. Now, if you look at the structure of growth hormone, which hormone does it resemble most?
It looks like insulin. Though, matlab, the
Does it look like insulin?
doesn't look.
Prolactin. So what is the difference between insulin and prolactin? IGF-1 looks like insulin. Growth hormone basically is a single chain. You look at it, this is a single chain. Insulin basically has got two chains, A and B connected. And what you're seeing here is the disulfide bonds which are there. So this is just like the prolactin structure. So what it tells us is that maybe a few million years ago, growth hormone and prolactin were the same molecule. Like we know that the AVP and the oxytocin gene were the same. They split as part of evolution. So later on, you had this split happen. Why is this relevant? As we discussed earlier, you have got the somatomammotrophs, which produce both prolactin as well as growth hormone. So that becomes relevant from that regard. So the structure is like a prolactin. It's a single chain, 191 amino acid polypeptide. This is non-glycosylated. Which peptides are glycosylated? So which hormones are the biggest usually? Is it the hypothalamic, the pituitary, the insulin, the parathyroid? Which are the biggest hormones? Smallest are hypothalamic. 3 amino acid TRH, 9 amino acid that is AVP, 10 amino acid that is GnRH. So these are like 191. This is a much bigger. Now within this group, you have got some which are glycosylated, the pituitary hormone. Which one are glycosylated? And that is very relevant from their half-life perspective. So gonadotropins, LH, FSH, HCG. The more they are glycosylated, the longer will be their half-life. So growth hormone is non-glycosylated and it has a disulfide bond which we talked about. Remember, there are other structures which are similar to growth hormone like prolactin. Human chorionic somatomammotrophine produced by the placenta also has structural similarity to growth hormone, and there are other structures as well. Now remember that growth hormone has got many forms. The most important form is the 22 kilodalton, which is the major form, and there are some around 20 kilodalton, which is 10%. Which one is the active form, and why is it important to understand that? So out of 22 and 20, which one is the active form? The 22 kilodalton is the active form. So what does it mean? If you have assays which are looking at both 22 and 20 as growth hormone, you would be falsely saying that the growth hormone is high, and you will missing the growth hormone deficiency. So that's why the recent recommendations, if you go via the Pediatric Endocrine Society recommendations, which are not that recent now, around 9 years ago, they said that the 22 kilodalton growth hormone should be estimated. You should not estimate the other forms. So this is important to understand whether your assay is looking at only this isoform, or is it looking at other isoforms as well from that perspective. So there are other variants which are there. Now, growth hormone is basically regulated at chromosome 17q22 via the gene growth hormone 1 gene, which basically has other hormones. You remember pre-pro-insulin, pro-opiomelanocortin, pre-pro-AVP. Similarly, you have got pre-growth hormone, from which your signal peptide and growth hormone is split. And then you have got the growth hormone, which is there. Now, will you be storing the growth hormone, or would you be releasing it immediately? What is controlling the regulation of growth hormone production?
What is controlling the production of the growth hormone?
GHRH.
Okay.
What is controlling the release? Somatostatin.
Okay.
And we know that for large peptide hormone, the major regulation is at the level of release, because you say that I want growth hormone. I can't produce it immediately. So I'll keep it ready, like all your big fighter planes are there. You can't say fighter plane can be made. So they're ready, and then you can immediately deploy. If you want bullets also, maybe you can produce quickly. So that sort of a thing can be done. So that's why growth hormone will be stored. And as soon as your somatostatin goes down, immediately your growth hormone will be released from there. Now there are other forms of growth hormone which are also produced via the placenta. Now I said growth hormone is a peptide. It is a unique peptide which is bound to growth hormone binding protein. It does not need it, but it is needed for mainly directing it to the right area and to increase its half-life. The growth hormone binding protein actually is the extracellular domain of the growth hormone receptor. So this concept that basically the target tissues are attracting growth hormone, you come here and act. We have got the receptor here, and then this is going to come back to the main tissue. This is also increasing the half-life. So people have studied that if you give growth hormone with GHBP, you may have a longer or a better action, but then it becomes too much of a complicated. So we only use growth hormone plain. Now this takes to the site from which then it's dissociated to act on the growth hormone. So it's a localizing thing. So this is a very important role of the transport protein. Now it is not a marker of growth hormone sensitivity. Why?
Because sir, the receptors. It is
So
a
there are
part
so
of.
many other variables. So when you talk about marker of growth hormone sensitivity, what do you want? A product which is dependent upon the growth hormone. So marker of growth hormone sensitivity will be
IGF-1,
IGF-1,
ALS,
IGF-BP3, ALS.
ALS.
So this is not going to depend upon the growth hormone level. Yes, theoretically you may say, okay, more receptor, more GHBP, but that has not been correlated. So GHBP levels are not recommended in routine clinical practice from that regards. As I said, there are a couple of studies which said that if you use growth hormone binding protein together, they may have a better response. But of course, this does not make sense. You're complicating the matters more in that regards. Now, what are the type of receptor? Growth hormone receptor is which type of receptor?
It is a tyrosine kind.
So everybody says tyrosine kinase. Type 1 cytokine receptor. Is type 1 cytokine receptor. Okay, and insulin? Tyrosine kinase. Okay, so it is basically going to act via the receptor which has got two extracellular and two intracellular domains. It is going to bind, which is GHBP, which is the same extracellular receptor. As soon as it is binding, it is going to open up the intracellular chains. The intracellular chains will open up, and you will have the JAK-STAT pathway which is going to be activated. So here you have got this JAK, which is the Janus kinase, phosphorylation happens, and you have got the STAT5B. STAT5B goes to the nucleus where it stimulates the steroid response elements, wherein you produce its products like IGF-1, IGF-BP3, and acid labile substrate on that regards. Now, if you look at here, so if you talk about the mechanism, we normally say steroid hormones are, where do they act? Where is the receptor?
Receptors are at the level of nucleus.
So steroid receptors are in the nucleus.
No, when they produce, the goes there and production is there actually.
So receptors are where? In the cytoplasm. So they are not in the nucleus. Which has got nuclear receptor?
Vitamin D.
Thyroxine. There are some of them which can have a nuclear receptor. So they are regulating the protein expression. But membrane receptors generally don't regulate the protein expression. So what are you seeing here?
Membrane receptor is.
So it is a membrane receptor which is regulating the effect through gene expression. What does it tell you about the onset of effect of growth hormone? It will be immediate or slow.
It will be membrane receptors are there, so it will be acute response.
But it has to go to the gene response element. So ultimately, if you look at it, the second messenger here is behaving differently. The classical second messenger, the cyclic AMP, cyclic GMP, IP3, DAG, they have immediate phosphorylation. But here, ultimately, you have the gene expression. So that is why the growth hormone effect will not be acute. There may be certain acute mechanism, but predominant work is through the SRE. So that is why it will take time for growth hormone to act. As against if you give, let's say, ACTH, immediately you will have the ACTH acts through which receptor?
MC2R.
Working through which pathway? AVP acts through which pathway? So you should remember all these things.
AVP acts on the V2 receptor, so CAM pathway will be there.
Cyclic AMP.
Cyclic
So
AMP.
predominantly it's cyclic AMP pathway which is there. So basically what I'm trying to say that they will have immediate action, PTH, cyclic AMP, immediate action. Here you will take time to act. So there are ways in which, now you have to understand is that steroids can also have a membrane receptor and rapid effect. And peptides can also have a nuclear effect. So it's not that they're completely exclusive. Most peptide hormones predominantly act via the membrane and acute action. Most steroid act via the genomic action. But that is a difference that you need to understand there in that regards. So from here, you have got the MAP kinase, the IRS, which is an insulin-like receptor substrate, which allows the glucose uptake. So remember, the effect of growth hormone are not just growth. So what are you seeing here? It's also activating the MAP kinase. So this is the immediate effect. It is allowing the glucose effect from that perspective. So growth hormone is also a lipolytic hormone. It is also going to increase your glucose in that perspective. So you may differentially regulate your growth promoting effect and your hyperglycemic effect and lipolytic effect. In which condition you see mainly the the lipolytic and the glucose production effect rather than the growth effect. In which disorder, disease, or state. So when you don't want the growth hormone, yes. So in malnutrition, you want glucose to be there, free fatty acid to be there, but you don't want growth. So these two become separate from that perspective. Okay. So there is also a protein kinase. So there are multiple things. So growth hormone is not only acting through the IGF-1, it is taking calcium inside, glucose inside. So the overall cellular growth is going to happen more in that regards. And then there are some variants which determine the growth hormone sensitivity. So do you think everybody responds same to the growth hormone? Every child responds same to the growth hormone, or there is a differential response?
The differential response.
So what are the common determinants of growth hormone responsiveness?
So we'll see increase in height.
Yes. So no, what I'm asking is that what determines, suppose you have a child whom you're giving growth hormone, which child is more likely to respond better to growth hormone? Number one, growth hormone level, do you think is important? Yes. Lower the level, better the response. Parental height, of course, more the parental height, more response. Height of the child is shorter, will he respond more? Or if he is not that short, who will respond better?
Shorter child.
So of course the deficit is more in that perspective. And these are some of the determinants which are there. Now people have also found that there are genetic differences in growth hormone receptor which can explain the responsiveness. And this is the exon 3 deletion. This deletion has an impact in terms of growth hormone responsiveness. And in between there was a lot of hue and cry about this, that you should do it in everybody. Suppose somebody is not responding to growth hormone, then you can consider this as a criteria to look at. It affects the growth hormone sensitivity. Now, similarly, theoretical studies have been done in animal models where they have seen that, okay, I give growth hormone and growth hormone receptor. What do you expect? The response will be better. But then giving too much peptide will be difficult. So if you give growth hormone alone, growth hormone plus GHBP, and growth hormone plus growth hormone receptor, who is the best?
Financially, growth hormone.
No, not financially. Just we're talking about response.
Response, growth hormone plus growth hormone receptor. If you
Because you are giving everything. And if you are giving growth hormone binding protein, the half-life will increase.
Yes.
Growth hormone theoretically will be the lower. Then of course, technically, how could you give such big molecules in a person? How will they go? Those things are there from that regards. Now, IGF-1, I said, is also the major mediator of growth hormone effect. IGF-1 acts via, it's similar to the insulin receptor. So it's basically going to act via the tyrosine kinase. It has got an intrinsic tyrosine. So IGF-1 binding to its receptor will again approximate its extracellular chains. While in growth hormone, we found it was like a scissor, like a catchy. So you bring it together, it goes out. Here they will come together. So what's happening is that these two will come together and then tyrosine kinase will start causing the phosphorylation. So what is the difference between this and growth hormone? Here that is separating and here it's coming together. There you had to take another molecule, Janus kinase, from outside. Here tyrosine kinase is intrinsic. That is the major thing. And this is going to cause phosphorylation. Again, it is going to act like insulin. So you will have a IRS, which is insulin related substrate, and PI3 kinase pathway. So two pathways are going to be activated. It is going to take glucose intake. It is going to activate the RAS pathway, the MAP kinase, to cause cellular growth. So when you talk about insulin and IGF-1, both are pretty similar. Both are going to cause hypoglycemia and are also going to cause cellular growth. IGF-1 will cause more mitogenesis. Insulin will cause more hypoglycemia. That is something to remember. It's an anti-apoptotic one as well. This is extremely important to understand from a physiological perspective. So conventionally, I said, you say growth hormone receptor, IGF-1. This is your path. Now, is it really true? So this IGF-1 is going to act on the IGF-1 receptor to cause the bone growth. But remember that growth hormone is not just acting via this pathway. There are many more effects of growth hormone in that regards. It, I already said, acts on the fat to cause lipolysis. So somebody who has got growth hormone resistance, what do you expect their fat to be? Now, if you compare this to somebody who has got no growth hormone, second, growth hormone is there, but IGF-1 is not there.
So they will have a normal fat status.
So their fat will not be that much. So now if you look at faces of children who have got typical Laron syndrome versus people who have got complete GHD, who is more plump? Who looks more doll-like?
Complete GHD.
Complete GHD. Because there this lipolysis is affected less. So their fat will be much more. IGF-1 also will have more fat, but they don't look like doll-like. That is the reason is that the growth hormone has a IGF-1 independent effect on lipolysis. So that is very, very important. Similarly, I haven't gone to that level. GHRH also has a growth hormone independent effect. You need to understand that. So if somebody has a GHRH receptor problem, what is happening? You've got low growth hormone, low IGF-1, but high GHRH. Compare that to somebody who has got not increased GHRH, low GH, everything is low. So what is the difference there?
In GRH deficiency,
GHRH receptor problem, they will have
no hypoglycemia, no micropenis.
Yes, so this is important. So it's not just that these three are acting in just all are going in one line, GHRH is also doing some work. So there may be some extra non-GH-IGF-1 mediated effect of GHRH, which are preventing hypoglycemia, which are preventing frontal bossing, micropenis, all those scenarios will be happening there. So now fatty acid will be released. Growth hormone also act on the kidneys to decrease phosphorus excretion. Now this I've already talked about. We use growth hormone in hypophosphatemic rickets where it is of benefit, and growth hormone also causes bones to grow. It has an effect on the liver, of course, to cause hyperglycemia. One of the major paradoxes between growth hormone and IGF-1 is growth hormone is a diabetogenic hormone, hyperglycemic hormone. IGF-1 is a hypoglycemic hormone. So this is completely different. Now, also you need to remember that growth hormone, besides acting through the IGF-1, has a local effect as well on the bone growth. And of course, IGF-1 acts on the liver to cause hypoglycemia. So if you now summarize everything, why is growth hormone better than IGF-1 as a growth promoting therapy? Suppose you have a case, I have said this is IGF-1 deficiency because of low growth hormone. You can either give growth hormone or you can give IGF-1. I'm not talking about resistance. That's a different ball game altogether. So one thing you said, the GHBP, the IGF-BP effect. What else?
Sir, independent effects of growth hormone.
Yes, so you won't be getting those effects. Very important second effect, hypoglycemia.
Hypoglycemia.
If you give IGF-1, they will have a risk of hypoglycemia. And the third, which we already mentioned, is that when you're giving growth hormone, BP, IGF-BP will also go up. So in that scenario, your free IGF-1 level will not jump up. That is why the risk of malignancy and all will be lower, and you have a much longer response. So the clear message is the only role of IGF-1 therapy in growth promotion. So when it was released, a lot of people were thinking about that IGF-1 will replace growth hormone. But now we know it should only be used if you have a genetically proven growth hormone insensitivity, or GHD1 where your growth hormone is not working, or somebody who has a very high level of growth hormone and who has not responded to growth hormone. So clinical trial of growth hormone becomes important.